Welcome to our video on proteinuria. Let's begin. In this lecture, we'll talk about transient proteinuria, orthostatic proteinuria, and persistent proteinuria. For each condition, we'll talk about definition, causes, clinical presentation, diagnosis, and management. Let's start with transient proteinuria. Transient proteinuria, as the name implies, is a transient protein excretion greater than 150 milligrams in 24 hours due to some type of physiologic stress. Transient proteinuria disappears after the physiological stress is resolved. There are several well-established causes of transient proteinuria. First, strenuous exercise in pregnancy can increase the urine protein excretion rate by increasing the filtration pressure in the glomerulus. High fever can increase the glomerular permeability, resulting in transient proteinuria. Exposure to the cold has also been shown to induce transient proteinuria. Transient proteinuria is most commonly asymptomatic. However, if proteinuria is severe, hypoalbuminemia and decreased oncotic pressure can induce peripheral pitting edema. Transient proteinuria is typically an incidental finding on urinalysis. At least 1+ proteinuria may suggest transient proteinuria. The proteinuria should be isolated without other urinalysis changes like urine, red blood cells, or CAS. As we already mentioned, 24-hour urine protein excretion should be more than 150 milligrams in order to diagnose any type of proteinuria. Importantly, in the setting of transient proteinuria, the first morning urine protein to creatinine ratio is usually normal. That is less than 0.2 grams of protein per gram of creatinine. This is because transient proteinuria resolves after the resolution of physiologic stress. Resolution of proteinuria is further confirmed by negative protein on urinalysis performed after the first morning protein to creatinine ratio. Let's talk about management. One needs to treat the underlying cause of transient proteinuria. However, the transient proteinuria itself does not need treatment. Additionally, serial urinalysis is not required after the resolution of proteinuria. A 19-year-old man comes to the physician for routine checkup. He's been working out intensely for an upcoming marathon. His partner has recently been diagnosed with chlamydia, which prompted the physician to order a urinalysis for the patient. The urinalysis shows 2+ proteinuria without white blood cells, nitrites, or leukocyte esterase. Repeat urinalysis after 1 week shows no detectable urinary protein. What is the next best step in management of this patient? The patient's urinalysis shows 2+ proteinuria without white blood cells, nitrites, or leukocyte esterase. In other words, although his partner has chlamydia, his urinalysis does not indicate there is currently an infection. Repeat urinalysis after 1 week shows no detectable urinary protein. This description is consistent with the diagnosis of transient proteinuria. The transient proteinuria is likely caused by his intense exercise regimen. The best next step in management in the patient with transient proteinuria is reassurance, because this condition is benign and has an excellent prognosis. Let's move on to orthostatic proteinuria. Orthostatic proteinuria represents normal urine protein excretion at night and high urine protein excretion during the day. This is associated with prolonged standing. This is why orthostatic proteinuria is also known as postural proteinuria. Orthostatic proteinuria is most commonly idiopathic. However, it can be caused by nutcracker syndrome. Nutcracker syndrome is compression of the left renal vein between the abdominal aorta and superior mesenteric artery. Backflow of blood in the left renal vein increases intraglomerular filtration pressure, inducing proteinuria while standing upright. Diseases that increase glomerular capillary permeability can also cause orthostatic proteinuria. These conditions include systemic lupus erythematosus, amyloidosis, and diabetic glomerulonephropathy, to name a few. Keep in mind, these conditions can also cause persistent proteinuria that we'll discuss later in this lecture. This is an illustration showing nutcracker syndrome. Please note the left renal vein is compressed between abdominal aorta and superior mesenteric artery. This leads to increased pressure within the renal venous system, which can increase the intraglomerular filtration pressure and lead to proteinuria. Orthostatic proteinuria, just like transient proteinuria, is most commonly asymptomatic. However, if proteinuria is severe, hypoalbuminemia and decreased oncotic pressure can induce peripheral pitting edema. Orthostatic proteinuria is typically an incidental finding on urinalysis. At least 1+ proteinuria may suggest orthostatic proteinuria. However, the proteinuria should be isolated without other urinalysis changes like urine, red blood cells, or CAS. As we already explained, 24-hour urine protein excretion should be more than 150 milligrams in order to diagnose any type of proteinuria. Importantly, the first morning urine protein to creatinine ratio is usually normal. That is less than 0.2 grams of protein per gram of creatinine. This is because supine posture during the night normalizes the urine protein excretion. The subsequent urinalysis done later at the same day will show positive protein. This is because the patient has been in an upright position for a considerable amount of time. Let's talk about management now. If there is any known underlying cause of orthostatic proteinuria, it should be treated. However, the orthostatic proteinuria itself does not need treatment. Additionally, serial urinalysis is not required after resolution of proteinuria. A 10-year-old girl is brought to the physician by her father for a well-child visit. Her urinalysis shows 1+ proteinuria. The first morning urine protein to creatinine ratio measured on the next day is normal. What's the best next step in managing this patient? The patient's urinalysis shows 1+ proteinuria. The first morning urine protein to creatinine ratio measured on the next day is normal. This pattern of laboratory results can be seen with both transient and orthostatic proteinuria. The best next step in the management of this patient is to perform repeat urinalysis later on the same day to differentiate between transient and orthostatic proteinuria. If repeat urinalysis shows proteinuria, then the patient has orthostatic proteinuria. If repeat urinalysis is negative, then the diagnosis is transient proteinuria. Let's talk about persistent proteinuria. As the name implies, persistent proteinuria is a persistent protein excretion rate greater than 150 milligrams in 24 hours due to glomerular, tubular, or systemic disease. In contrast to transient and orthostatic types, persistent proteinuria is not related to physiologic stress or upright posture. There are several subtypes of persistent proteinuria depending on the underlying etiology. Glomerular proteinuria is caused by increased glomerular capillary permeability, enabling albumin to be filtered into the urine. Causes of glomerular proteinuria include all the nephrotic and nephritic syndromes, which will be covered in detail in a separate lecture. Tubular proteinuria, on the other hand, is due to impaired reabsorption of small proteins in the proximal tubule. This can be seen in acute and chronic forms of tubulointerstitial nephritis. Overflow proteinuria is caused by increased systemic production and delivery of proteins to the glomerulus. This increases the filtration fraction of proteins and overwhelms the reabsorptive capacity of the proximal tubule. Causes of overflow proteinuria include multiple myeloma, rhabdomyolysis, and intravascular hemolysis. Multiple myeloma causes increased delivery of immunoglobulin light chains, also known as Bence-Jones proteins, to the glomerulus. Rhabdomyolysis results in filtration of myoglobin released from the muscle. Finally, intravascular hemolysis causes filtration of free plasma hemoglobin, which is not bound to the haptoglobin. Post-renal proteinuria is an increased protein excretion due to a disease of the urinary collecting system. There are 3 main causes of post-renal proteinuria. These include nephrolithiasis, urinary tract infection, and urinary tract cancers like urothelial carcinoma. Here's an illustration summarizing the types of persistent proteinuria. As we already discussed, glomerular proteinuria is due to increased glomerular capillary permeability. Tubular proteinuria is caused by impaired reabsorption of small proteins in the proximal tubule. Overflow proteinuria is induced by increased systemic production and delivery of proteins to the glomerulus. Finally, post-renal proteinuria is due to the disease of urinary collecting system like nephrolithiasis, urinary tract infection, or cancer. Now let's talk about clinical presentation. First, hypoalbuminemia and decreased oncotic pressure result in lower extremity and periorbital pitting edema. Other signs and symptoms depend on the specific etiology of persistent proteinuria. For example, dark urine is seen in nephritic syndrome due to hematuria, rhabdomyolysis due to myoglobinuria, and intravascular hemolysis due to hemoglobinuria. Xanthomas and xanthelasmas are subcutaneous lipid depositions seen in nephrotic syndrome. This is because nephrotic syndrome is characterized by hyperlipidemia. Pain may accompany nephrolithiasis and urinary tract infections. Finally, cancers of the collecting system like urothelial carcinoma can be accompanied by significant weight loss. Here are photos showing edema. On the right side, you can observe pitting edema on the lower extremity. On the left, you can appreciate the periorbital edema. Let's talk about diagnosis. Urinalysis will show at least 1+ proteinuria, which may or may not be accompanied by other changes like urinary red blood cells, white blood cells, or casts, depending on the specific etiology. A 24-hour urine protein excretion should be more than 150 milligrams in order to diagnose any type of proteinuria. Importantly, the first morning urine protein to creatinine ratio is abnormal, that is more than 0.2 grams of protein per gram of creatinine. Other diagnostic procedures depend on the suspected cause of persistent proteinuria. Renal and bladder ultrasound as well as cystoscopy can be performed if nephrolithiasis or cancer is suspected. Urine culture is done to exclude a urinary tract infection as the cause of proteinuria. Finally, kidney biopsy is needed to definitively diagnose nephritic and nephrotic syndromes. Management of persistent proteinuria also depends on specific cause. Nephritic and nephrotic syndromes are usually treated with corticosteroids. Antibiotics are needed for urinary tract infections. Chemotherapy, radiotherapy, or surgical excision is needed to treat a malignancy causing persistent proteinuria. Here's a table summarizing all 3 types of proteinuria along with their key features. Pause the video and take a moment to review this slide. A 35-year-old woman presents to the emergency department with diffuse body aches. She's been exercising 9 hours per day for the last week for an upcoming marathon. Her past medical history is significant for acute post-streptococcal glomerulonephritis at the age of 12, a kidney stone 5 years ago, and a urinary tract infection 3 months ago that was treated with antibiotics. Her vital signs include a temperature of 37 degrees Celsius, blood pressure of 90/70, heart rate of 125, and respiratory rate of 16. Her serum creatinine kinase is 2000. Her urine is dark. The urinalysis reveals 3+ proteinuria and 2+ hematuria. The urine microscopy shows no red blood cells. Which of the following is the most likely cause of the patient's proteinuria? A. Glomerular proteinuria. B. Tubular proteinuria. C. Overflow proteinuria. And D. Post-renal proteinuria. This patient presents with diffuse body aches. She's been exercising 9 hours per day for the last week for an upcoming marathon. Her serum creatinine kinase is 2000, which is severely elevated. The urinalysis reveals 3+ proteinuria and 2+ hematuria. However, the urine microscopy shows no red blood cells. These findings are classic for rhabdomyolysis. Rhabdomyolysis is muscle breakdown due to strenuous exercise, which releases myoglobin in the blood. Myoglobin is filtered across the glomeruli and gives the urine the red color. Myoglobin is also responsible for 3+ proteinuria in this patient. Since rhabdomyolysis causes excessive delivery of the myoglobin to the glomeruli, the proteinuria in the case of rhabdomyolysis is overflow proteinuria. Therefore, the correct answer is option C. Here's a slide reminding us of the mechanism and causes of overflow proteinuria. So let's discuss why other options are incorrect. Option A, glomerular proteinuria, is incorrect because it's usually seen in nephritic and nephrotic syndromes. Although this patient had acute post-streptococcal glomerulonephritis at the age of 12, this would not result in proteinuria at her current age of 35. Option B, tubular proteinuria, is incorrect because it's usually seen in the context of acute or chronic tubulointerstitial nephritis. Finally, option D, post-renal proteinuria, is incorrect because it's associated with urinary tract infection, urothelial carcinoma, or a kidney stone. Although the patient previously had both a kidney stone and urinary tract infection, both these conditions have resolved. Therefore, they would not explain her current proteinuria. And that concludes our lecture on proteinuria.